I'm so delighted to welcome you here today to this webinar, which is hosted by the Maternal Mental Health Alliance and King's College London. Thank you so much for joining us. I'm Laura Seabohm and I'm Chief Executive of Maternal Mental Health Alliance. So for those of you who don't know us, the Maternal Mental Health Alliance is a charity and network of over 130 member organisations which span from community grassroots groups, national charities and royal colleges and lots in between. And we also have a network of lived experience champions. And really what our role is, we bring together that voice of people with lived experience together with clinical and professional voices to speak as one, to ensure that all women impacted by mental ill health during pregnancy and after birth have access to high quality support and compassionate care. So at the MMHA, the Alliance, we know that no one single organisation can affect the positive change needed. So it's working together and collaborating really brings about impact. And this is why we're so pleased today to be joining up with King's College London for this webinar to mark the launch of their new research, the ASPEN study, which explores the experience of women and birthing people who had a suicide attempt during the perinatal period. So this is such valuable and vital research because we know that maternal mental health problems are very common and can be very serious. Before we start, just a bit of housekeeping. Obviously, today's webinar is about suicide, and this can be really difficult listening. So please, just a reminder to really look after yourselves. There is information on the MMHA website on where to get support if that's what you need in listening today. We are going to hear from a range of experts, women with lived experience, researchers, healthcare professionals and leaders will speak about the existing evidence and why specific attention on preventing suicide in the perinatal period is so necessary, and the evidence on the stark inequalities that some women face and how we can make things better, most importantly. So we really hope that you will find this session informative and thought-provoking. There'll be a panel session after the presentations, so if you have any questions for our fantastic speakers, please submit them via the Q&A function. Before we start, very quickly, I just want to ground ourselves in some of the facts. So about 600,000 women give birth every year in the UK, and at least 1 in 5 of those will experience a mental health condition, either during pregnancy or the 2 years after giving birth. Tragically, suicide is the leading cause of death for women between 6 weeks and 12 months after birth. And the Embrace confidential inquiries into maternal deaths have found that suicide has been a leading cause. They report this year on year on year. Despite this, we know that mental health is still not given equal attention or resource compared to physical health during pregnancy and early motherhood. So we need decisive action to change this. There has been welcome progress in recent years with the development of specialist perinatal mental health services across all 4 nations of the UK. And perinatal mental health is specifically mentioned in the suicide prevention strategies in England, Northern Ireland and Scotland, and very hopefully soon to be featured in Wales as well. But we know that much more is desperately needed. And today's webinar, sharing this new research, is a landmark to really pin down what needs to happen. It's groundbreaking because at the heart of this research is really listening to women and families to drive the learning and they play the most meaningful role to deliver change. So enough from me. Our first amazing speaker, I'd like to hand over to Holly, who's a lived experience speaker. And Holly, we're delighted to have you joining us this morning. Thank you.
Thank you, Laura. Thank you for having me here today, and thank you in advance for listening to my story. So a few years ago, I was the happiest person in the world. I was pregnant. I knew we were having a daughter, and I was just super excited. I couldn't wait to meet her. I was desperate to meet her. So I was really happy and looking forward to everything and becoming a mum. Unfortunately, my labour was horrific. It was frightening. Lots of things went wrong, and I thought that I would die, and I also thought that my baby would die. She suffered a brain injury because of the birth, and she was taken away from me, so I didn't see her. And a few hours later, when I went up to the ward to see her and meet her for the first time, she stopped breathing and she turned blue in my arms. Again, she was taken away to a neonatal intensive care unit, and I couldn't hold my baby. I couldn't feed my baby. And it felt like I was in some kind of living nightmare. I didn't know if she would survive. And as parents, it was the most traumatic experience that we'd ever been through. We just sat beside her, not knowing if she would live, listening to all the beeps, and just wondering if we'd hear any good news anytime soon. By the time I got home, I just felt broken. When I got home, I had a rush of feelings of failure, that everything was my fault. I couldn't give birth to her safely. I couldn't keep her safe, and I hadn't protected her. I was terrified of something really bad happening to her again, and I was scared to be alone with my own baby. I was having quite frequent flashbacks of the birth and of the neonatal intensive care unit, and of her being intubated. I was frozen to the ground. I couldn't move, and I just watched these people, what looked to me like hurting her, but are actually saving her life. But to me, it looked like they were hurting her. I was having nightmares every night, multiple times a night, and I was too scared to go to sleep because I knew I'd be waking up. Sorry. I would just keep checking her and checking her to see if she was breathing. So I'd fall asleep and I'd wake up and I'd think that she had died next to me. I was in a lot of physical pain because of the injuries that I sustained during the birth. And I was really hypervigilant, and my anxiety was sky high. And the worst thing was that I just felt so sad all the time. I just felt desperately sad all of the time. I genuinely thought that my husband and my daughter would be better off without me. I was ashamed of myself. I remember really vividly seeing the cracks of the light come through the window in the morning, and just thinking to myself, I can't do it anymore. I just can't face another day. I cannot do it. I couldn't cope anymore. I was so desperate, and I was really low. And at my very lowest, I just couldn't see a way out. It all got too much, and I made plans. Luckily, because of my daughter's condition, we had lots and lots of appointments for her in those first early weeks. And during one of the appointments, I got really upset. And this lovely lady said to me, "This is really common. This happens a lot to a lot of women. You're not on your own. Would you like to speak to somebody?" And I'll always be grateful to that woman. I was transferred to the perinatal mental health team, and I was diagnosed with PTSD. And fast forward a few years, we're all doing really well. So when I think of my daughter eating pancakes at breakfast this morning, being as happy as anything, I just feel so grateful for her, but also for the perinatal mental health team. My hopes and the wishes for the future are that we can reduce the stigma around mental health, and especially perinatal mental health. We need to talk about these things. We need to know how common they are. There is support out there, and it just needs to be, the awareness needs to be raised, and the services need to be promoted. I was just what I like to think of as a normal person in my 30s, excited to have my baby, couldn't wait to be a mummy, and I had a loving partner, and it's really frightening that I went from that to suicidal within those short couple of months. You can get better, people do get better, but they need the right support and the right help. I have really great hopes for our future. I'm grateful every single day for the perinatal mental health, but mostly for my daughter. You're not alone, and no baby should grow up without their mummy. Thank you so much for listening.
Oh, honey, thank you so, so much. We are so, I mean, your story is so full of gratitude, but we are so grateful to you. And the overriding message, you're not on your own, and you're not, but it's so important that that message gets out there. So thank you. What an incredible start to really make us think about the reality of what we're talking about today. So thank you. We're now going to hear an overview and an update on the research findings on maternal suicide. I just want to reiterate, I said at the beginning, but this is hard. We need to look after ourselves in the course of this webinar. So please, everyone, do that. I would like to welcome Dr. Andrew Cairns, who is psychiatric advisor to the confidential inquiry into maternal deaths and a consultant psychiatrist at an amazing specialist perinatal mental health team up here in the Northeast, where I am from. So I visit regularly, and Andrew is going to give us an overview of the Embrace findings on maternal suicide. Andrew, thank you so much for joining us.
Thank you, Laura. Can you hear me all right?
Yeah, really well. Yeah,
thanks. Apologise for those of you on the call. I'd had a bit of trouble joining earlier, hence joining on my phone. So hopefully it'll work okay. I would just really echo Laura's comments about Honey's story. I think such a powerful story, and sadly experiences that are very common. I think it's good to hear that she had a positive experience of the care that she was provided by mental health services. I'm just going to take a few minutes just to briefly update you on some of the recent lessons from the maternal deaths inquiry. Can we just move on to the next slide, please? One point that I just wanted to make before we go into some of the details is the nature of the inquiry. So the inquiry, which has been running now for many decades, since the early 1950s, works on a retrospective basis. So we identify all of the women who die in the perinatal period from pregnancy through to 1 year postpartum, and retrospectively analyse their health records, GP, midwifery, health visiting, mental health, where they are involved, to learn and find lessons from those very, very sad cases. It's all fully anonymized, so in the process of this, it's very much based on expert judgment about what was going on, and it does mean that we're not able to make any prospective analysis of care that's provided. I just wanted to remind you of that. Next slide, please. For those of you who have seen presentations regarding mental health from Embrace previously, this slide will be very familiar. And as Laura was saying at the start of this webinar, these numbers really have not changed all that significantly for at least 25, if not more, years. Mental health causes, that being those deaths through suicide and related to substance misuse, remain very substantial killers of women in the perinatal period. Antenatally, in the most recent data from the 2023 report, suicide is the third most common cause in pregnancy and up to 6 weeks postpartum. And the pie chart on the right-hand side, if you look at the large segments on the right, the blue, which relates to substance misuse-related deaths, and the orange, which relates to suicides, these are the late deaths from 6 weeks postpartum up to 1 year. And as you can see, and this has been consistent over several decades, these two big, broad mental health related causes of death are by far the largest chunk of late deaths. And this proportion is not changing. If anything, it's probably a little bit larger over the past few years as a proportion. The numbers, the absolute rates, which are listed along the top there, have gone up in recent years around the COVID period, and it remains to be seen whether they will drop back slightly to the historic pre-COVID levels, which were typically around sort of 2.7, 2.8 per 100,000. Next slide, please. when we look at suicide occurring in the perinatal period, historically, we've seen a pattern where the majority of these were occurring in the late period from 6 weeks up to 1 year postpartum, and that's represented on the little grey chart up in the top left. In 2020, so the first year of the COVID pandemic, we saw a significant shift and increased numbers of women dying through suicide antenatally. So it's about a threefold increase in that 1 year. Whether this data will be borne out as we've come out of the pandemic remains to be seen, but clearly a significant concern that there's been that shift. And we know that often suicides antenatally are associated with precursor incidents of self-harm as well. Next slide. Again, very common message over the last couple of decades is that suicide in pregnancy and postpartum is by and large violent in its mode. The proportions have changed very little over the years, with hanging predominantly being the most common cause at around half of all suicides. Other violent means, jumping from heights, jumping in front of trains, also forming that portion. And of course, the importance of this is that it really gives us very little opportunity to intervene. We need to be actively treating these thoughts and expressions of violent self-harm extremely seriously at this period of life. Next slide, please. So as an example here of the red flags is this vignette, and those of you who are aware of the red flags from the report, these are rapid, sudden deterioration in mental state, thoughts and acts of violent self-harm, as I've mentioned from that previous slide, and also feelings of estrangement or incompetence as a mother. And I think we'll probably be hearing a little bit about that from the ASPEN report today. And this vignette, very much represents that sort of case. A woman who died violently 2 months postpartum, had no prior history, which is not uncommon with psychosis, postpartum psychosis. She had developed depressive symptoms and had these feelings of inadequacy as a mother, who was described as being quite guarded in assessments. And despite offer of mother and baby unit, admission was managed in the community and sadly died through suicide subsequently. Next slide, please. Of significant concern from data in 2020, but also actually from a couple of years leading up to the COVID pandemic, was a shift that we've seen in the numbers and the rates of teenage suicides in pregnancy and the postpartum period. Historically, we'd seen around 2 or 3 cases every 3 years. The reports are produced on a 3-yearly basis. But in the 3 years preceding COVID, so 2017 to 19, there had been a shift in that, and there were 7 under 20 deaths in that 3-year period. And it was unclear at that stage whether this was going to be a continuing trend. And indeed, in 2020 alone, there were very sadly, very further 5 young mums who died from suicide in that period. Now, this increase is really quite significant. So it represents about 11-fold increase compared to that historic baseline, and is approximately 27 per 100,000 maternities when looking at that particular age group. And comparing that to rates of suicide from ONS data in 10 to 24 is the age frame that they use, when looking at 2.5 per 100,000. So you can see quite a substantial difference. All of these young mums had really complex background, mental health difficulties, substance misuse, domestic abuse, and all of them had their children removed into care, which I think fits with a lot of the trends that we're seeing in these cases. Next slide, please. And this really represents that data which I've just described. Next slide, please. I think one of the significant things that I just want to flag very briefly with you is about risk assessment. And often we've seen, again, over many years, a pattern of statements being taken on face value by those assessing women in this period. So particularly comments about children or family members being protective factors. This vignette, which I'll just give you a moment to have a read through, really illustrates the importance of looking at the overarching pattern. I mentioned earlier that often in these cases of suicide, we see precursor acts of self-harm. And this was very much the case from this particular woman who died. And a sense that the assessor in that moment took what she was telling him about the children being protective at face value and didn't recognise this real repeated pattern of acts of self-harm and didn't put in place a plan to try and manage that. Next slide, please. We've heard from Laura at the start there that we've got better access to perinatal services, and that is indeed a really marvellous development. Perhaps to be expected. We've seen a number of women coming through the Embrace inquiry who've now had access to those services, and certainly some learning from that for the teams in terms of who they assessed. Next slide, please. In particular, difficulties with referrals and engagement with community teams of those women being referred in. But of note here, I just want to make the point about quite restrictive referral criteria. When we're seeing this real pattern of complex adversity in many of these cases, restrictive criteria around diagnoses such as personality disorder, for example, are particularly unhelpful in groups of women who may be at significant risk of self-harm or potentially suicide. Next slide, please. So we've seen a real common pattern of complex adversity in many cases, and this isn't just in relation to suicide, but also deaths from substance misuse, homicide, and accidental deaths, indeed. And I think this really highlights the importance of having a much more multi-agency approach. This is not something that mental health services in of themselves will be able to address. And final slide, please. In terms of the cases that we review in the maternal deaths inquiry, so the advisors are asked to rate whether they felt the care was good, whether the improvements could have been made that would not likely change the outcome, or if improvements could have been made that would have made a difference to the outcome. As you can see from this table, around 75% or so of those women who died through substance misuse, and the same is true of suicide as well, the advisors found that there was evidence that improvements could have been made, and about a quarter of those, we thought that there may have been a difference to the eventual outcome. Thank you very much.
Thank you so much, Dr. Andrew Cairns. Thank you. And yeah, a lot of food for thought, and especially really thinking about the inclusivity of people, all women, you know, regardless of, you know, adversities and complexity, you know, that's what we're here for. And thank you so much, that really comprehensive overview of such the Embrace reports, which are just groundbreaking and amazing every year, so important. I'd love now to welcome Dr. Abigail Easter, who's a reader in perinatal mental health at King's College London. And Abigail's going to provide a summary of the research landscape in this area. So over to you, Abby. Thank you.
Great. Thank you very much, Laura, for the introduction. So I'm very briefly just going to introduce some of the research context before handing over to Kat, who's going to talk about the ASPEN study findings. And this is really the context that's kind of led to us conducting this research and holding this webinar today. So we've heard from Andrew that suicide remains one of the main causes of maternal deaths during pregnancy and in the year following birth. But despite this, there is actually limited evidence to guide suicide prevention in this group. And where we do have evidence, we know that it's not always being put into place and actions being taken. So I'm going to highlight some of a few key pieces of research just to put the ASPEN study into context. We know that there's data from cohort studies and case note reviews such as the Embrace that we've had an overview of that have highlighted prevalence of suicide at a population level and potential risk factors such as mental illness, domestic violence, for example, which are really important to consider within the perinatal context. And there's emerging findings on qualitative studies that I think are really important as we see to kind of just help us understand some of the quantitative data. Next slide. So I really wanted to focus on what is it about the perinatal period that is important? And we've heard from the Embrace data a little bit about this. This study was a really important study that was led by Professor Louise Howard and her team at King's College London, that looked at the data from the UK National Confidential Inquiries into suicides and homicides for people who with mental illness who were in touch with psychiatric services. And just to highlight a couple of key findings from this study. So what they found was that compared to non-perinatal women, women who died from suicide in the perinatal period were much more likely to have a diagnosis of depression, as well as a recent onset of illness. But despite this, they were less likely to receive an active treatment at the time of their death. So I think this really highlights the importance of kind of the active and insertive follow-up of treatment. Next slide, please. And we were also interested more recently to look at the treatment that was being received and follow-up treatment for women who had a hospital admission for self-harm during the perinatal period. As we've heard from the Embrace report, this can be a red flag that also requires assertive follow-up. And we looked at this data over a 10-year period. And what we found was that among the 448 admissions, around 2/3 of those were in the postnatal period, and amongst women who had had prior contact with mental health services in South London. So these were women who were known to mental health services. And again, when we looked at kind of the follow-up of mental health support being provided in that year after their admission, only 27% of the women were seen by a mental health care professional within 24 hours. And looking at the data, this only increased to around 33% follow-up from mental health services within 7 days. So again, this really highlights the importance of acting upon the evidence that we have and that assertive follow-up of groups of people that may be at risk. Next slide. So very briefly, and I know we're going to be thinking about this throughout the webinar today, but how can access to support be improved both from mental health services and other services? Some qualitative research has already highlighted several barriers to providing responsive care. And we know that recognition of severity of risk can be quite challenging, and particularly within the perinatal period. The study also highlighted that actually communication of risk can also present a challenge, so particularly between maternity services and mental health services, where there are multiple agents involved in caring for people. And also where there is a risk identified, a lack of appropriate service provision and access to rapid treatment. Finally, I just wanted to highlight some findings from a group of researchers at City University who have been looking at how we can improve identification of suicide risk within maternity services. And what their research has highlighted is that very many maternity healthcare professionals actually feel uncomfortable about asking or dislike asking many of the existing kind of standard suicide related items unhelpful, and so often they're not put into practice. And we know that whilst many women often want to be asked about their mental health and their feelings around suicide, they also find that the current items on the risk assessments are largely unacceptable in their current form. And much of the barriers to providing support is driven by kind of stigma, fear, and shame, which are central to non-disclosure. Final slide. So really this has led us to the ASPEN study, and I think we can probably all agree that listening to women's experiences and women and families' voices is central to research and to preventative action. And the ASPEN study has been co-designed with women and with stakeholders, and I've just highlighted here some of the processes that have kind of led to the design of this study, which I won't go into too much detail just because of time today. So I'll stop there and I'll hand over to Kat, who is going to be talking about some of the findings.
Thanks so much, Dr. Abigail Easter. Abby, that's really helpful. And just as an introduction to Kat, this is Kat de Blacker. Doctoral Research Fellow in Maternal and Perinatal Mental Health at King's College London. And Kat's going to give us an overview of her research, which is really just out now, the Attempted Suicide in the Perinatal Period, or ASPEN study. And thanks so much, Kat.
And thank you, Laura. It's a great privilege to be able to share with you these findings of our study. As Laura mentioned, the paper is just out, and we'll put a reference to that at the end of the talk. Next slide, please. As Abby mentioned, we wanted to cover quite a lot of ground with the ASPEN study, but today I'll focus on the first study aim, which was to explore experiences of women and birthing people who had one or more suicide attempts during the perinatal period. Next slide, please. To take part in the ASPEN study, interested participants had to be 18 years or older at the time of interview and had one or more suicide attempts in pregnancy or the year after birth. And this happened within the last 10 years in the UK. Most importantly, we wanted to ensure that participants were safe prior, during, and after the interview, and we had a very robust safety protocol in place, which also included an optional debrief with a clinical psychologist. Next slide, please. In total, we interviewed 11 people with almost an equal split between those who had a suicide attempt during pregnancy and those with an attempt in the year after giving birth. The vast majority of our participants were able to access secondary mental health care, either through community perinatal mental health services or an admission in a mother and baby unit. Unfortunately, a few women required admission to a general hospital for their injuries. And it's important to highlight that some of the attempts that women reported to us were prevented at the very last minute, either by a member of the public, a loved one, or the woman herself. Next slide, please. Now, during the analysis of the interview data, we found 3 overarching themes, each with their own sub-themes, which we will further explore in the next few slides. And it's important to mention that participants were able to choose their own pseudonym if they wish to do so when they were able to sense check all our findings. And all quotations in the next few slides, therefore, are not women's real names. Next slide, please. Our first theme captures the trauma and adversity that many women experienced at some point in their life. In our sample, almost all respondents reported previous or ongoing traumatic events, such as bereavement, miscarriage, infertility, fractured relationships, and domestic abuse, which for some had only started in pregnancy. And Laura said, it was a punishment, actually, that I dared to be pregnant, even though he knew I wasn't on any contraception or anything. And it really shocked me because he had never, ever been like that before. Several respondents shared that they had experienced previous mental health difficulties prior to pregnancy and could see why this might impact their mental health during the perinatal period. And Rosie told us, I have terrible things happen to me in life about failed marriage and fertility problems. Big things that I've sort of managed with a strength of mine that I perhaps didn't have in my late teens or early 20s to overcome. So I guess it was always on my radar, knowing the stats around you're more likely to have perinatal mental health problems if you have bouts of depression in the past. Several respondents, next slide please, had a family history of perinatal mental illness. For some, this was not something which had been spoken about prior to their own experiences, as you can see from Rosie's quote. She said, I didn't know that my mum had postnatal depression. That's not anything she'd shared. And others were highly aware of their family history and vigilant that they might experience something similar, and actively actually sought preconceptual mental health support, as Sarah mentioned. My mum had severe perinatal mental illness. She was hospitalised after my older brother for a year without him. And then I came several years later and she was hospitalised again and she died by suicide. So because of that collective history, when we were trying to get pregnant, we thought we need to let someone know we're trying to get pregnant. Next slide, please. Our second theme brings together feelings of disappointment, fear and apprehension around motherhood. And we call this theme disillusionment with motherhood. All participants held hopes and expectations of what their pregnancy, birth, or the postnatal period would be like, but they became disillusioned by the physical and mental health struggle of pregnancy and birth. Simone told us, there's all these things about pregnancy. You're supposed to be glowing and it's all marvelous and you've got these wonderful hormones. But I was just beached on the sofa, feeling hot and sweaty, thinking, when is this baby going to come out? When is it going to come out? Next slide, please. Our second sub-theme captures the invalidation of identity and self-sacrifice. Almost all respondents encountered negative experiences with healthcare professionals and felt invalidated and dismissed by these. They reported they were not seen as a person with a complete identity, but reduced to a vessel for their baby and with little consideration given to their own feelings. Selena told us, it was never about me. I know it's not all about me, but when I'm wanting to commit suicide and it's very much about me, and not one person asked me if I was all right. For some, the invalidating experience would almost become a motivating factor to succeed in their suicide plans, as they felt the severity of their mental health problems was brushed under the carpet. And Hannah told us her shocking experience. So I think a few more weeks went by and I went back to the doctors and I said to the doctor, I want to kill myself. And he said, well, if you wanted to kill yourself, you would have done it by now. And I sort of felt then I've got something to prove. Next slide, please. A third sub-theme captures the internal conflict between wanting to be a perfect mum, yet not feeling a bond with their baby. Many, many women reported issues with bonding. And as one person said, I would have jumped in front of a train for him, but it wasn't like a starry-eyed love. Next slide, please. In the phase leading up to the suicide attempt, women experienced an overwhelming feeling of hopelessness and entrapment, with seemingly no way out, hence our theme name of entrapment and despair. The first sub-theme we identified under this theme is feeling like a failure, an overwhelming sense of incompetence and failure, both as a woman, a mother, and partner, instilled a feeling that their baby and loved ones would be better off without them. Simone shared with us, so it just escalated. It was later that week where I still wasn't sleeping and I just thought, do you know what, the both of them would be better off without me because I've just failed, I'm just a failure. They will be better off without me. Next slide. More than half of the women in our sample reported intrusive ideas or unsettling experience in the period preceding the attempt, which is captured by this sub-theme. For some, this was in the context of a psychotic episode, but for others, they could be described as intrusive thoughts in the context of obsessive-compulsive disorder. Rosie shared, it was an intrusive, scary thought that I just couldn't control, and they'd come out of nowhere, and they really panicked me. Next slide, please. While these distressing experiences of failure and intrusive thoughts invaded women's mindsets, they felt profoundly alone and isolated. For some, it was the absence of their partner who had to return to work after paternity leave that served as a lever for an acute deterioration of their mental health. Sarah shared with us the following. Everything was fine until about 3 weeks after the birth, and we were back at home and my husband went back to work. It was him going back to work, and I fell apart. Our sub-theme, Tired and Wired, captures the profound impact of sleep deprivation in the days or weeks before the suicide attempt. And this was often in combination with high levels of hypervigilance, arousal, or anger, leaving them tired and wired, as Sam described it. I stopped sleeping entirely. I was so angry all the time. It's all the textbook depression symptoms, but I felt so angry all the time, so tired all the time, but just wired, couldn't sleep. Next slide, please. A majority of our respondents described they came to a very agonizing realization that they were unable to get out of being a mother and that they found themselves in an irreversible situation with no going back. Sam was able to articulate this in such a profound and painful way. It was this doom. I used to describe it as a black cloud that just hung over me all the time. And every single day I would wake up and I would think, oh no, I'm a day closer to having this baby. And it caused all these feelings of regret. But you can't ever say those things out loud because people will assume that you want an abortion or that you made a reckless decision, or you wanted this. It's very much like you chose this, you wanted this, this is your lot. And it got really bad. It got to the point where prenatally, I would just generally hope that I wouldn't wake up the next day, because that was one day closer to having the baby. Next slide, please. Based on the stories that participants so generously shared with us, we have identified some key clinical recommendations that hopefully will be useful for those of you that work with families during pregnancy and the year after birth. Next slide, please. First of all, our study highlights the importance of routine inquiry of previous mental health difficulties in family history of perinatal mental health problems, including trauma and grief in its widest, broadest terms. Secondly, while every encounter creates an opportunity for screening, detection, and support, it is key to realize that every encounter also has a potential for invoking or deepening trauma. Professionals need to fully understand the profound impact of physical and mental health challenges of pregnancy and childbirth, often in combination with a traumatic birth. In addition, the impact of an impaired mother-infant diet, feelings of resentment of motherhood, and the discrepancy between women's expectations and their lived reality are all key triggers that should be discussed and addressed at the earliest opportunity to avoid further escalation. Insomnia and sleep disturbance, albeit in combination with restlessness and irritability, intrusive thoughts and feeling of lack of control and failure are red flags for severe and rapid mental health deterioration, as Ambrose has also clearly highlighted. But more than anything, women need to feel safe and listened to, so they can share their feelings with healthcare professionals without fear of judgment, shame, and stigma. Next slide, please. If you want to find out more, the paper is, as I said, now published. It's open access, so you can either scan the QR code or somebody will put the link in the chat, and I think Tony's just kindly done that. Next slide, please. And then on behalf of the entire study team, I want to thank all the participants in the study and all of those that made the study happen. And thank you for listening.
Goodness, thank you so much, Kat. I think just before we move on, just to absolutely acknowledge the amazing sort of testimonies of the participants from this study is unbelievable. And also thank you, Kat, for the very sensitive way that you presented just really some really painful experiences. So thank you very much. The next part of our webinar is really going to look at the prevention, why this matters. And we are really, really delighted to have with us today Professor Lewis Appleby, who leads the National Suicide Prevention Strategy for England. Lewis is the director of the National Confidential Inquiry into Suicide and Safety in Mental Health and Professor of Psychiatry at the University of Manchester. And Lewis is also a great champion of the importance of perinatal mental health work within the wider suicide prevention agenda. And thank you so much, Lewis, for joining us today.
Well, thank you for having me, Laura. I'm doing something that academics do when they're prepared to take risks, and that's speaking without slides. So I don't know whether that's what you're seeing, but yeah, thanks. That's what it looks like now. Yeah, so no self-respecting academic would come to a meeting without slides. It's part of our training to cower behind the Zoom screen, but I'm not actually going to do that. But that's partly because I do apologize. I'm sort of coming here and then dropping out, although I have heard the last couple of talks, so thank you very much for the evidence you've presented. And I wanted to be here because, Laura, as you say, I have a bit of a history with this topic. So when I was in clinical practice a little while ago, my clinical specialty was perinatal psychiatry. And I worked in that field for quite a while before I had to make a choice about research or clinical practice. And it's the sort of thing that happens to a lot of psychiatrists. I'm not unique in that sense. We have to change sometimes, but I never quite lost that interest. And I hope I can be doing justice to it now. If you look at the training of psychiatrists, you know, when my own kids were young, I was very interested in perinatal psychiatry, and then as everybody got older, I became interested in the suicide risk in middle-aged men. And following the logic, I'm likely to make a step into old age psychiatry at some time in the near future, which, strangely enough, is what happened to the first person to give a modern clinical description of postnatal depression. It's Bryce Pitt, who wrote the first paper on this subject in 1968, and who did become an old age psychiatrist. Anyway, I digress. What I wanted to tell you about today is the National Suicide Prevention Strategy, which was published in September. It was the first new strategy for England for suicide prevention that we'd had for 11 years. And it went through quite a long period of preparation, partly because of the degree of turmoil in the government, and partly because we were doing our best to take people's views as to what ought to be priorities within it. So when it came out, we hope that it updated a lot of areas of evidence, that it reflected changes in what we understand about suicide, who we understand might be at risk, and also what wider popular opinion might tell us. And its message was that anyone can be at risk, and that everyone has a part to play in prevention, a universalist message. But alongside the universal, you have to be able to say who you are most concerned about. Government strategy has to say, yes, it's for everyone, but there are certain groups that we want to draw your attention to, wherever you are in the system, in the NHS or in local authorities or in wider society. Here are the people who we want to express concern about. And the groups of concerns, we came to call them, there are several of them, and they have the characteristic, as in these kind of documents, of being groups who are at high number and high risk. So to give you an obvious example, mental health patients, 1,300 mental health patients die by suicide every year. So that is a very large component of the overall national suicide problem. But we also wanted to reflect some other aspects of the concept of suicide. And for the first time, perinatal women were presented in the national strategy as a group of greatest concern. So bear with me on the language. And reflecting that, Laura has joined, for a time anyway, our national advisory group, just to give some focus, some profile to the importance of this area to the national suicide prevention effort. Why did we choose perinatal psychiatry? It is partly for the reasons you've already been hearing about. It isn't always about overall statistical risk. The issue can sometimes be about where suicide fits into the wider questions about safety. And so the fact that suicide was the highest, the most frequent cause of death in perinatal women, that was a very important factor. Proximity to services, it's another way of saying preventability. People whose risk arises alongside the services that might protect them. Very important factor. There was the long-term impact of suicide, and you could argue serious mental health, not just on the woman who experiences it, but on her family and on her developing child. So the potential benefit from being able to intervene where a woman in the postnatal period might be suicidal seemed disproportionate, maybe greater than in some of the other groups that we were concerned about. So these were all important reasons. And then there was one other one, which for some reason I've been thinking more about in relation to our strategy in recent months since we published it. And that is about society's outrage. That sometimes there are subjects in mental health which, putting aside some of the numbers and the research, and I am a researcher, so I don't say that lightly, that sometimes what we're talking about is how society views an issue. Society can sometimes tell us, and you find this if you do public consultations, that something that happens is just unacceptable. It challenges our values. It doesn't sit with the people we think we are. And I think perinatal suicide is one of those things. that it's society telling us that that whatever the numbers are, this is not acceptable. It is not acceptable that at that period in a person's life they might be at particular risk. So perinatal women became a key priority in the strategy, but of course the importance that inclusion goes beyond what it says about perinatal services, because the relevance is to all women. It raises issues of the economic stresses that some people face. It raises a concern about teenage women and the particular risks they might face. It raises a concern about domestic violence, an important factor. And so the message for the strategy starts with perinatal mental health, but it spreads into women, families in poor circumstances, sometimes facing domestic violence, struggling with aspects of childcare responsibilities, and our responsibility reflecting society's concerns to do our best. So that's where the strategy has got to. And some of the things I've just been hearing you talk about are picked up by that. The concerns about women in their early 20s, suicide concern I'm talking about. The rising self-harm rates in women, they've been rising for about 20 years now. So all of these things show the interplay between the perinatal issues and the wider problem of suicidality in the female population. So so that's where we've got to with the strategy. Very important, I hope, as a signal as to what's important. But I want to just spend the last couple of minutes referring to going back to the point I started with, which is how for me this is full circle, because I used to work with a pioneer of perinatal psychiatry called Chani Kumar. I don't know how much people now talk about Chani, but Chani was an international leader in this field in the 1970s and 80s and 90s. And I, in training, worked with Chani, and he taught me a lot. And together we did a number of studies, which I just want to mention to you. We studied the first liaison psychiatry service attached to an antenatal clinic. So this is a service in which mental health professionals supported midwives in the antenatal care, the antenatal mental health vigilance that they offered. We did the first study in the UK of suicide by perinatal women, which actually it was interesting to hear the confidential inquiry into maternal deaths being mentioned and how it started in 1953, because that was the data source. So we used that. We spoke to women themselves, which didn't always happen at that time, and asked them how they viewed. These were people who were depressed. Asked them how they viewed their depression, and you won't be surprised to hear that they didn't view it as depression, and that was very important to the kind of help that they thought they needed and whether they would seek help at all. And it just struck me listening to the previous speakers that. How these are enduring themes. And of course, society changes and the context changes and the population structures change and the health service changes. But these are still enduring themes. Who is at risk? When are they at risk? In what way are they at risk? And what is the responsibility of our services to provide proper support? These are still the vital questions. And I must say, I congratulate you at the Maternal Mental Health Alliance, but also the researchers presenting today, Embrace, ASPEN. These questions are vital, and they haven't become any less vital over time. I want to mention finally one other question that used to be thrown at me as a clinician in this field, which was about mother and baby units. So it was part of my responsibility to run the mother and baby unit in Manchester, and we were constantly being asked to justify the cost of a mother and baby unit, to the point where we feared, almost every day I feared I'd get a memo saying that we were about to close. And the argument about why those units were valuable was an important one to be able to make, but it was an incomplete argument at that time. And now, please don't tell me I'm wrong, but I don't actually hear people making that argument now. These are vital units as part of the NHS. And nobody seems to want to shut them down. And the question is, why has that happened? And I think it has happened because campaigners, voluntary sector organisations have made an articulate case. I think it's happened partly because of better research evidence. but I also think it's happened because of the narratives, the stories that women tell, families tell, about the importance of perinatal mental health and the importance of services responding to what they tell us. A crucial component. I sometimes wonder why suicide has become such a more widely discussed issue in society than it used to be. And those same narratives, those narratives of people who've been through the experience of suicidal crisis of all kinds, has been the crucial factor. And so too in perinatal mental health. So those personal stories are vital. And the more we can hear from about those stories, the better. Thanks very much for having me today, and I hope the conference goes as well as I've heard it to go so far.
Lewis, thank you so much. I think what you've just finished with there gives us real sort of hope and drive, doesn't it, around what we're doing, around campaigning, around really listening to women, actually making change, and that's what we're here for. So thank you so much. It's great to see you. And actually on that theme, I'd now really love to welcome Fen, who is going to speak from lived experience to us. So Fen, hi and welcome, and it's really lovely to see you today.
Hello, hi everybody here. So yeah, I'm Fen. I've got 2 children who are 6 and 8 now, and unlike quite a few of the other people mentioned, I do have a history of mental health problems. So I first had psychosis in my 20s due to an untreated water infection, and I was suicidal with my second pregnancy, but I had postpartum psychosis following the birth of my first child. So I did spend a couple of months at an amazing mother and baby unit. The depression kind of started for me at the 12-week scan. I distinctly remember sweeping my backyard after the scan and thinking, oh shit, I've invited it back, and the psychosis is just going to get me now. I kind of thought I was over it enough to try for another baby sort of 18 months later, but I don't think I had processed it really. And I just became really low in mood from about 12 weeks pregnant throughout the rest of my pregnancy. Sort of, it didn't change over those months. I think I found access to services really difficult while I was pregnant. So when I went to my midwife appointments, they all seemed very much focused on baby and how well baby was doing. And a lot of the physical, I did have some physical problems. I had gestational diabetes, which I got a huge amount of support for, and numerous hospital appointments and extra scans and medication. And I had to test my blood sugar 7 times a day, which just as part of my depression just made it even worse, having to do all this stuff for this baby. And I just thought, I don't know what I'm doing anymore. But yeah, I suppose I had 2 suicide attempts during my second pregnancy, and one came straight after a midwife appointment. So I walked to my midwife appointment from my house, and they didn't ask me anything about how I was doing, and I was still really depressed. And I just thought, I just felt hopeless. I just thought, I can't face this anymore. It's too much. And I didn't want to lose the baby, which I know doesn't make much sense, because obviously if I died, the baby would probably die as well. But it wasn't really about that. I just felt like I was a waste of space. So I tried to get run over by a bus, but I didn't succeed. I didn't step out at the right time. I never really told anyone about that. And then it was sort of a few weeks later, and I was a stay-at-home mum with my daughter, who was 2 at the time. And I just felt really isolated. I wasn't really seeing anyone. I didn't have a community psychiatric nurse checking in on me, or any of the support I'd had postnatally after the psychosis. That had all stopped after a year. So I didn't have any of that support in place. And I had, at 12 weeks, I was admitted to a psychiatric unit, 12 weeks pregnant, but obviously it was an adult psychiatric unit, and there wasn't much follow-up from that admission. And that was just with suicidal intentions, no actual acts. And then I got to about 26 weeks pregnant, and I'd been at home alone with my daughter all day, and we'd had a long day. I think she was going through a difficult time, and my husband wasn't due home for a few hours, and I just thought, this is it. I kept thinking I could like flick a switch and it would all just go away. And I couldn't work out how to do that. So I gathered all the tablets in the house. It was mainly ibuprofen, and I just necked them all in the kitchen with my daughter at my feet. So I took about 30 odd tablets, and then kind of thought, oh, I've done it now. And there wasn't any relief, and I just rang my husband and told him what I'd done, and he rang 999, and the ambulance came and took me in. Doesn't really end there, because everything was fine. Got baby checked over and got admitted to a adult psychiatric unit, but there wasn't one for bed free near me, so I was sort of an hour from home on an adult ward, mainly older adults. And the perinatal team had been aware of my pregnancy and actually visited me at that unit, even though it was out of their area, and just said, we can't do anything till you're 32 weeks pregnant. And I was sort of 6 weeks away from that mark, and I just thought, I don't know if I'm even going to get there. But we made a plan that they would see me at 30 weeks and admit me to the unit at 32 weeks, so that at least I'd be safe, because I think they knew how strong my intentions were. So yeah, 32 weeks, I went back to the same mother and baby unit I'd been with when I had the psychosis, and I got all the support that I needed. And I actually gave birth at 36 weeks, so I had premature labour. And I went straight back to the unit for a week just to see how I was, but all the hormones and everything that had caused the depression had gone once I'd laboured. So I had lots of great follow-up care, which luckily I didn't, I had more support than I needed, really. But during that pregnancy, I just felt completely isolated, and like a carrier for a thing that everyone was really bothered about, and the person carrying it didn't matter to anybody. That's it.
Oh, Fen, thank you so much. It's just really, it's sort of, I think, shocking to hear that isolation and just some of that sort of criteria that sort of gets in the way. And at the same time, we hear time and time again, oh, once someone gets to the mother and baby unit, then it's okay. It's so powerful. And I just thank you so much for sharing that. And if you don't mind staying with us and joining with Honey as well as we move into our panel, we also have Dr. Andrew Cairns is kindly staying on our panel with Dr. Abigail Easter. And then we have two more amazing women on our panel. Thank you so much. So I'd love to introduce Grace Narty, who's lead midwife, maternity trauma and loss care service in Northwest London, and also Dr. Chrissy Jayaraja, who's consultant perinatal psychiatrist with real expertise supporting women facing multiple adversities. What a fantastic panel. I'm just checking my time. So we have about 15 to 20 minutes for questions and answers. And I've seen that there's some really interesting questions coming into the Q&A function, and please do all keep asking. If it's okay, I'd really like to start though, just really directing a question, first of all to Grace, and then to Chrissy, and then opening up, if that's okay with everyone. Grace, one of the findings of the ASPEN study is the importance of routine inquiry. I think we've heard a lot today about being asked, it's so important, and asked again, and the sensitivity of that around any previous mental health difficulties, family history of perinatal mental health we've heard, but also just how women are, new and expectant mothers are. As a midwife, it'd be really helpful just to hear, what are the challenges that you see about having those kind of really meaningful conversations with women about suicidal thoughts and feelings? And hopefully whether you see there are opportunities to make real positive change in that space.
Thank you. Apologies, I've just had to change devices because I lost connectivity.
Oh, sorry. Thank you for finding
that's no problem. So the challenges are, and we talk about this a lot of the time, it's really about breaking that stigma, not just stigma in society. There is also stigma around, I say stigma, but yet the difficulty for staff to feel that they're able to approach certain conversations with our pregnant women and birthing people. I also think as well, in terms of slight lack of resources, and what I mean by that, yes, we do have perinatal mental health specialist midwives located in our maternity units working. Not everyone works as full-time perinatal mental health specialists. Some are actually having competing other challenges as working on the shop floor. This is a conversation that's been going on for quite some time, and especially in our maternal mental health forums where we have specialist midwives, we have perinatal mental health specialist forums where they constantly speak about those challenges. And some of the conversations that come up from that is around ensuring that we have time for educating staff, ensuring that our services are fit for purpose. For it to be fit for purpose, we need to spend more time educating our staff, making people feel comfortable about asking these questions. But I think there's a lot of systemic issues. We don't have enough midwives. Most maternity units are challenged with recruitment. For us to be able to offer continuity of care, I am a great believer in continuity of care. And with that, midwives are then able to see their caseload of people, get to know them, build relationships. If they have the training and they've got the infrastructure of support there, and that's not just support from other specialist midwives, but the wider support, how perinatal services relate with maternity services. The area that I work in, they work really well. I can't speak that for every area. So there are lots of things that we have in place, but aren't able to fulfill everything that we need to be able to give a service that is personalized, a service where we also have staff that feel fully confident to ask questions. But I think at the same time, homing in that care that we offer needs to be personalized as well, and that women and birthing people need to feel heard. So
that's so much of what we've heard, isn't it, today? Yeah. Especially from Honey and Ben's amazing conversation with us. Thank you so much, Grace. And I'd like to ask a question firstly to Chrissy, but also Andrew, I think with your expertise, comment on this, please. So, you're both psychiatrists working within a specialist perinatal mental health team, supporting women. And I know from my experience in this role, both of you really reach out to support women, both with really severe conditions, but also really embrace and inclusive around women with more sort of complex needs, really, having such a commitment to women facing more multiple adversities. So starting with Chrissy, I mean, you know, I know you talk a lot about domestic abuse and women with history of trauma, and just really wanting to think about how we can sort of deepen our understanding and make sure we have more inclusive services, whether that's training and education. Just to speak a bit more, we've had quite a few questions in the Q&A about what you mentioned, Andrew, around, you know, that some groups of women being excluded from accessing specialist services because possibly, this is my language, the complexity of their needs. So it'd be amazing if both of you would speak to that. Firstly, Chrissy, hello, and lovely to see you.
Hi, thank you for inviting me, Laura and Karen, and hello everyone, good afternoon. It's a really good question. It's a very complex question, and I'm aware we don't have much time, but I think you know, one of the things to bear in mind, and actually women who have struggled with past traumas, domestic abuse, or even issues around their mental health, there's one thing about feeling safe enough to express that. We know that the research, particularly around domestic abuse, is that many women will not disclose to health professionals about their past history, or if they're going, even if current history, if they're going through domestic violence, and it may take even 5, 6, 7, 8 times to tell a health professional that they're going through it. And also it might take them as many times to leave a relationship. It's never so straightforward. I think it also, similar to something that Grace just mentioned right at the end, is about confidence in health professionals as well. There's one thing about all of us saying, you know, we've got to ask women the questions, we've got to be, you know, more on the ground. But the question I think we need to bring back to ourselves and our services is, well, what do we do with that information? And do staff members feel confident to deal with that information? So, for example, if someone did disclose something to you, whether that be they're having suicidal thoughts, whether that be their partner has been abusing them, what would you as a health professional do about that information? And do you feel confident and know the pathways where you work, or who to talk to, or how to escalate that? So I think that's a huge thing as well. In terms of thinking about our services, perinatal services as a whole, and how we could be more inclusive, I think, you know, think globally. I don't know, think globally about mothers with babies and toddlers in tow and trying to get parking at your local hospital. It's an absolute nightmare. And I know I did some work with the Maternal Mental Health Alliance a while ago, thinking about utilising spaces in the community. So thinking about children's centres, thinking about baby-friendly spaces that mums and babies can be seen. You can bring your kids along. There's not a massive sign on the wall saying psychiatric unit. And also other things that we do, for example, around the country, we're just having joint maternity and mental health clinics, so that when you go to your antenatal clinic, you could be seeing a psychiatrist like myself, or you could be seeing your obstetrician or your midwife. It doesn't, we all should be working together. So it's ways of thinking creatively. How can we reduce the stigma? Because we know there's a stigma around mental health. We know that as a fact around the world, and particularly, you know, in the UK. But there's also a stigma around motherhood and experiencing mental health in motherhood. I remember once doing some training, giving some training with the great Gwen Ashted, forensic psychotherapist, and she said, calling someone a bad mother is one of the worst insults you can give someone. And I think that says it all. You know, we have this idea about motherhood and being a good mother and a bad mother, but actually we should be thinking about working together to kind of neutralize those stigmas that we face, and having safe spaces to talk about what's going on.
Absolutely, it comes up time and again. Thanks, Chrissy. Andrew, would it be okay for you to sort of respond to that question as well? I think you raised it in your presentation so powerfully. We've had quite a few Q&A questions, just wanting to hear a bit more about that from you.
There's a few about personality disorder, wasn't there, as a sort of exclusion. I think just to try and summarize this very briefly, because you could spend quite a long time talking about this. If we, for those of you who've come across this term, leave aside for the moment the stigma about this particular diagnosis and just think about how this has come or may not have come into perinatal services. So personality disorder, fundamentally, we're talking about conditions in which people's personality traits have been impacted by childhood adversity, trauma, or attachment. and leave them to have enduring difficulties in how they relate and understand to the world. Hence why we talk about it as being personality trait. And historically, certainly if we go back even within the sort of early years of my own psychiatric career, this tended to be conceived as being a relatively untreatable situation that mental health services did not have interventions to offer for. Now, thankfully, that view has changed, and there was a big piece of work about personality disorder not being a diagnosis of exclusion. I think there's another reason as well, because if we think about the origins of perinatal mental health services, and we heard Lewis talk about Channy and other people like Margaret Oates who developed these, they were focused very much on a gap, which was women who were well, potentially in pregnancy, but had a history of severe illness and were at significant risk of relapse, for which they weren't getting adequate preventative care. And because perinatal services focused on that starting point, I think perhaps we weren't always as quick to the mark at identifying other groups to work with. And so there are still some services around the country, as far as I'm aware, where they tend not to work with this group and focus on psychotic bipolar diagnoses, particularly postnatal depression, and not those women with personality disorder as a label, for example. I think the difficulty here is because of how we understand the basis to this problem and the trauma and what we've heard about from Embrace in terms of complexity and trauma. What comes through very strongly is theme 1 in the ASPEN report. This is a group who are very much at risk, and both mums are at risk, birthing parents, and also the children, because of the impact it has on the parents' attachment with their baby as well. So I think this is a very important group that we need to be working with. I think just very briefly, there's another group of exclusion, and they are also the women who have their children removed. And many perinatal services also don't work with them, but I will leave that thought with you.
Thank you. That's such a huge piece of work. I think for Maternal Mental Health Alliance, really keen to build on that. Thank you so much. There's so much to think here. I wish we had so much more time. I would like, there's one question which I'd like to just ask anyone who wants to just jump in. And then I've got a final question for the panel for Honey and Fen, and before we close. So just very briefly, if it's okay, I just wanted to ask any thoughts. I'm just bringing in this one, which we just thought was a good question. And just to acknowledge, there are many questions that we haven't been able to include, you know, some on neurodiversity, on media, brilliant questions. I so wish we had more time. But just very briefly, just any of the panel jump in to respond to, what do you think of the value of peer support in the perinatal period? And what is the best way of involving the voices of mothers and fathers in shaping peer support and other suicide prevention initiatives during this stage? And that's a huge question. But you know, obviously we will not do it justice. But if just anyone on the panel just wants to say one or two thoughts, please just jump in, or just to show me that you want to respond.
I'll respond just quickly, just saying that we actually have our peer support worker on this panel, which is absolutely amazing. I would say peer support workers are crucial to ensuring that we get care and what we offer correct and right and fit for purpose. I need my peer support workers around me to keep me grounded in terms of what they see is important, because it's easy for me as a professional to actually make plans, but I think it needs to be fit for purpose. But what they bring is their personal experiences that enables me to actually think much wider than my remit as a midwife delivering care. But I also see that it's really important that we keep our peer supporters well supported, that there are layers of support that they have to keep them able to be a support, not just to us, but also to our clientele that we see. And I just wanted to put that out there.
Thank you.
They are
Brilliant.
absolutely valued.
Thank you, Grace. Next, Andrew.
Very briefly, I think peer support workers are of huge value. And one of the things that I notice time in, time out is just how much more easily they are able to understand what's going on for the women that we're working with, particularly some very sensitive information that even after all my years of experience of building that rapport, our peer support workers do a fantastic job at listing that and helping us understand the risk that we're dealing with.
Brilliant. Thank you. And Chrissy.
Yeah, absolutely. I think I was just in a meeting earlier before I joined the call about thinking about peer support workers, and actually peer support workers and perinatal service particularly are trailblazing in terms of the use of peer support within the mental health sphere. So, you know, with that trailblazing is also uncharted territory. So it's kind of, they are creating the role as they go along, and they are dealing with the highs as well as the lows and the in-betweens of being the first, really, in that sense. I agree with both Andrew and Grace, but it's really, I wanted to just emphasize the importance of supporting the peer support workers, because I think we as clinicians take it for granted the amount of discussions that we have every day around things that are very triggering, very risky. We talk about suicide, you know, having a cup of tea. You know, it's a day in, day out for us, particularly many of us who've been working in mental health for years. And all of us, not just peer support, but all of us are at risk of developing you know, stress and illness related to that, to our occupation, as well as burnout. And I think the people on the front line are the ones who get burnt out the quickest in all professions. So I think we really do need to make sure that we support our peer support workers and all our staff actually on the front line, because this is hard work. I think working in perinatal is very rewarding. It's the best job I think in the world, but obviously I'm biased. But it is very hard work, and you need to make sure that all of the staff are in maternity and also in perinatal feel that they're adequately supported to get through everything that they hear and see every day.
Thank you so much, Chrissy. And moving on to, I mean, you described as trailblazers, Honey and Fen. If it's okay to have a final question for you both. And what I'd like to ask is, from your experience, what would you, maybe 2 or 3 things, what would you tell other women who may be feeling similar to what you experienced? What would you like to say? I don't know. Honey, do you want to go first? And then
Yeah, sure. Thank you so much for saying what you did just now, all 3 of you, about peer support. And as you know, I work alongside Grace as a peer support worker for the Maternity Trauma and Loss Care Service. And I think it's around, you know, connecting with these women. You know, I've been there. There's no judgment from me. It also inspires hope. You know, you can get better. I think that's the biggest message that I wanted to give. You know, there is hope. And I know how it feels. It does feel like there's no help, it's a desperate situation that you're in, but there are living examples of people who have been in that black hole and who have come out the other side, as long as they've been able to access that help and support. You know, all I can say is I love being a mum and I just wish I'd known that at the time, and know how good life can be once you come out the other side.
The real story of hope. Thank you so much, Honey. And Fen, have you got any thoughts that you would like to share with any other women?
I think just keep talking, I suppose, and don't be afraid to share those feelings or thoughts, even though you think they're a bit strange. Just try and voice them to somebody that you trust, so that you're not left alone with your thoughts. I think like the study showed, that feeling of isolation is so prevalent amongst pregnant women and women in the postnatal period. But if we can just make connections with a few, I mean, I didn't have a peer support worker, or there wasn't one on the mother and baby unit, and there wasn't one when I was antenatally poorly, but that would have made a huge difference if I'd have met someone who'd been through a similar thing, that I could have talked to. I probably would have disclosed quite a lot of my thoughts and feelings to them at the time.
So absolutely crucial, you know, and I think this theme of listening to both you, Fen, thank you so much, and Honey, around, you know, stigma and trauma. It's all about, there's something just so intrinsically about feeling like you're the only one, and there's something wrong with you individually, and you know, the hearing from other people with lived experience is really like throwing a lifeline, and actually literally throwing a lifeline in many cases. Thank you so much. And that feels like finishing with your reflections, Honey and Ben, feels the right place to end. I'd like to say an enormous thank you to everyone. Thank you to all our panelists. Thank you, Honey and Fen, for sharing what you have so amazingly and so powerfully. And this is what, you know, as Lewis said, this is what has the impact to make change. Thank you as well, going through the you know, your testimony is also the research behind it, to Kat and Abby, the amazing ASPEN research. It's going to be so groundbreaking, this study. And a thank you to the MMH team for putting this webinar together so we can share it with so many. So we come to the end. It's felt really, really quite profound. Everyone, please look after yourselves now, because I think there's so, you know, we've heard a lot, and it's just really a lot to think about. We want to do this because for the MMHA, we really want to impact and influence change. Just one thing to say, which feels a bit flippant after everything we've heard, but we have an election coming up this year, or very early next year. And our campaign messages is all about everything we've heard today. And we're really keen to influence government. So we have an advocacy day where we're just going to do a massive push to government parliamentarians on the 1st of May to really reinforce these messages from today, and our campaign messages about perinatal mental health, investment and parity of care for mental health and physical health. So Tony has just put the link on our website to how you can just support that on the 1st of May if you want to. We would love you to. So the link to that is in the chat. But just close by saying, please look after yourselves, and thank you so much for amazing speakers. It's been a really real privilege to be with you today. So go well, and thanks again.